pun intended. Renal denervation, it's tough. It's tough to talk about any of these topics in 10 minutes, but I will do my best. I know we're behind on time. You know, and what's 10 minutes when we've spent most of our lives dealing with managing hypertension anyway? I'll be honest with you all, it's not one of my favorite things to do. I'll take lipid management all day, every day, because at least the LDL seems to respond sometimes. Hypertension is becoming quite tricky. A lot of our patients are not responding to some of these pharmacotherapies. And, you know, the longer I do this job, the more holistic I've become. I'm getting kind of tired of just prescribing medication after medication, but, you know, lifestyle modifications can only go so far, and that's assuming you can get your patients to do it. So I think we are entering a genuinely exciting era. Technological advancements have finally given us an option beyond simply escalating pharmacotherapy, and I think that's where we're at with renal denervation. I do have a confession to make. I was a skeptic, and I think we were all skeptics because renal denervation died. It was around during fellowship, and then it just died. It got shelved. And so when it came back, and I had the opportunity to become involved with it, I was very skeptical. I was like, well, how come it didn't work the first time? And it turns out, you know, the more questions I ask, the more research I do, the catheter wasn't the same. There was one electrode, now we have 4 electrodes. The location of the ablations were a little different. And so I think now we have a little bit more data. The data is starting to talk to us a little bit more. Technology matured, the trials improved, and we can no longer ignore what we're seeing. So I went from a skeptic to being cautiously interested, and now pretty much a genuine believer. But I will be, again, completely honest with you all, it does not work in everybody. And that's something we're all trying to figure out in this renal denervation world, is who it's going to work for and who it's not going to work for. And again, we don't have that quite figured out just yet. You know, the RAS system, you know, we talk about it a lot, especially with regards to heart failure and hypertension. But I went down a little rabbit hole for this talk, because you think about RAS. We got the ACEs and the ARBs and the ARNIs, and we know that's directly involved with the RAS system inhibiting it. Then you got your MRAs. We know that's directly involved with minimizing aldosterone effects. So ACE2 will cause vasoconstriction. Aldosterone, as you all know, will cause sodium and water retention. And so the MRAs and the ACEs, the ARNIs and the ARBs, no question. But then I started thinking, what about the beta blockers? How are they involved with RAS? Well, it turns out that the beta-1 receptors, the juxtaglomeralar cells, they're directly responsible for the secretion of renin. So there is some inhibition of RAS when it comes to beta blockers. So I said, okay, let me check the SGLT2 inhibitors. Same thing. The SGLT2 inhibitors, they cause the macula densa to be engorged with sodium chloride, which directly diminishes renin secretion as well. So all 4 of these pillars that we're using for GDMT, they're all involved in RAS. And the sympathetic tone, when it comes to the renal arteries, play a direct role. So how do we minimize that sympathetic tone? Well, we kill the nerves. And that's essentially what we're doing with renal denervation. As far as the anatomy and the location of the nerves arborize. So proximally, you got the nerves. They are more scattered and more distal to the location of the artery. As you go more distal, they become more compacted and more closer to the surface. Now that's important, because part of the reason why renal denervation wasn't so great in our early trials is because a lot of time was spent in the proximal vessels. So this is something that we've learned throughout time and technology, and now we're treating more distally as opposed to more proximally. And we have 2 great devices commercially available that help us do both. This is some anatomical configuration showing you the arborization of the renal arteries and how they become more condensed the more distal that we go out there. For the most part, the majority of the renal nerves are within a 6 millimeter depth from the vessel wall. 2 modalities commercially available, 2 energy sources, 2 energy forms, 2 different ways to achieve the same goal. We're trying to turn the nerves off through heat, whether that's with the high-intensity ultrasound wave, which is what the ReCore Paradise balloon does, or radiofrequency ablation, which is what the Medtronic spiral catheter does. Again, both technologies work, irreversibly heating the nerves in an effort to minimize sympathetic tone affecting the kidneys. And it's almost like the superficial vein work that we do. My goal is to close the saphenous vein. Whether I'm putting cyanoacrylate adhesive or whether we're ablating it, you're putting Varithena, laser, they all achieve the same goal of closing the vein. So here we can see different ways in which the technologies work. So in the first column, you see this is the ReCore device, the balloon. You get a circumferential distributive fashion of energy transformation throughout the entire vessel and the surrounding tissues. I'm sorry, it didn't show the other one. But the other radiofrequency device, it conducts radiofrequency through localized conductive heating. So a little differently, the ReCore device gets more tissue penetration, and the radiofrequency device gets a little less, but there's some advantages to both and disadvantages to both. And I'm not here to talk about one versus the other because they both work, and I've utilized both of them. The Paradise system, sorry, on that previous slide, very simple. They both come with generators, both come with balloons. It's a pretty simple procedure, guys. Any interventionalist should have no issue doing this. It's nothing to shy away from. I think some of the questions we should all have when it comes to denervation is, okay, I am trying to inhibit the nerves, but what does the heat do to the surrounding tissue? And here we have a histology slide of a swine artery showing that despite the denervation that we've done, you still have preservation of the endothelium, of the vein, and the lymph nodes have not been affected. And I think that's important for us to understand that even though we're essentially nuking the entire tissue surrounding the artery, we want to make sure we're not causing any other damage that we might not see, whether early on or late. 3 trials, all from the Radiance. These are the pivotal trials for the Paradise balloon. Around 500 patients, half randomized to the procedure, half randomized to a sham procedure. And this is what I wanted to point out. You can see in all of these studies, about 2/3 of patients had a response, and 1/3 did not. But the ones that did achieve a response, it's pretty measurable, about 14 to 17 millimeter reduction. And I can tell you personally, using denervation, we've been able to get patients off of 1, maybe 2 medicines, but not all of them. Again, there are some patients who maybe we've been able to reduce some dosages of medications, and then you get some where we're able to take some away. And again, it's hard to predict who's going to respond and who's not. And that's something that there's a lot of talk about, and we're trying to figure this part out right now. Safety. Again, this is not a procedure I think that anyone should be overtly concerned about. I think the biggest risk is just don't poke a hole in the kidney. And first, when I was doing this, I'm used to coronaries and legs where I want a lot of support from the wire. And I was parking my wire pretty distally. I hadn't had any adverse events, but I realized, okay, I don't have to do that. It's a straight shot. You don't need that much support. You have a big guide in there. And so just avoid the wire. I use a non-hydrophilic wire with a big safety loop and just try to keep that wire from causing any damage, because I really think that's the most risk involved with this procedure, apart from the vascular access. And so here in the Radiance pooled MACE events, there was 1 death not procedurally related. There was 1 patient who had a vascular complication, required an intervention. Another patient was hospitalized with hypotension, which probably isn't that bad of a thing considering we're trying to cause, reduce blood pressure. But overall, team, these procedures, whether you're using ReCore or Medtronic, overall very, very safe. This is showing you what the Medtronic spiral catheter looks like. Now, as opposed to the ReCore balloon, which comes in different sizes, 3.5, 4.2, 5, 6, 7, and 8, the Medtronic catheter is a one-size-fits-all. And it has a nitinol self-expanding mechanism to it, and it will conform to the size of the vessel. And so the larger the vessel, the shorter treatment zone that you have, but not by much. The kidneys are pretty cool. I didn't spend too much time in the kidneys before this. I mean, there was some renal artery stenting here and there, but not much. And the more you spend time in the kidneys, the more you appreciate the complexity of them, but also the simplicity of them. You clearly can see the demarcation of the kidney bean. And that's important because you do not want to ablate or ultrasound anywhere near the parenchyma. That's pretty important. And so part of the difference between ReCor and Medtronic is with the ReCor device, you really stay in that large lumen area. You can go distally, but you don't want to go inside all those smaller branches. As opposed to the Medtronic device, you can go inside the smaller branches. It's a little more work, but overall, because we know that the nerves do end up converging distally, it might not be a bad thing. But overall, again, both technologies work. I've had success with both of them. This is some of the pooled data from the Medtronic Simplicity Spiral study, about 2,000 patients. And again, you can see up to 3 years, you have sustained reduction in blood pressure throughout, as opposed to the initial data that I showed you all from ReCor, that was about 2 months. So from 2 months to 3 years, we're seeing sustained reductions in blood pressure. And I just want to say something about coding too, because, Dr. Loyoka gave a great talk, and I guess, where's Dr. Bhatia? He's gone, because I'd like to meet Dr. Oz. I think that'd be cool. He is basically telling us that there is no technical code for this procedure right now. It has an NTAP code for inpatient and has a TPT code for outpatient. There is no CPT code, which I find fascinating, that we live in a world where procedures exist and there's no code for the physician, and technically there's no real code for the hospital either, but they're still able to get some reimbursement out of it. So right now, 2025, 2026, where with this NTAP TPT situation, they'll probably expand it another year, and by 2028, we'll have some definitive data that would kind of guide the reimbursement for us and hopefully get a CPT code. There's no reason why this procedure can't be done in the ambulatory surgical center from a safety standpoint, but financially it cannot be done right now. It doesn't make sense. So in closing, I just want to thank you all. I hope I didn't spend too much time. I didn't go over that much, but please, any questions you all have, I am happy to answer for you all.